But there are multiple non-communicable well-defined cystic lesions, and then CD is homogeneous and low on T1 and high on T2. Near biopsy shows areas of connective tissue, so this link back to T. If I have multiple stab wounds to the lower abdominal blood pressure, 80 by 40 mm edge of reduced resuscitation, ureteric entry is expected, what would you recommend? Single shot IVU. 26 transfusion cycle carcinoma of the bladder, which is true in staging investigation, at MI tumors isotense to muscle on T1 and hypertension on T2. Then 27, a number of pressure techniques are employed in mammography, which is not included. See the allowed tube current is not seen in mammography. 28, 34-year-old woman presents with left lower abdominal pain or sound through the complex diagonal lesion which cannot be fluid characterized. A might 5 cm fluid structure with incomplete non-enhancing plaque causing it and with areas of low focal and peripheral small low signal intensity nodules on T2W. A model shading of the lesion is also seen on T2. Enhancement of the wall of the lesion of the ganglion administration is noted. Now, ovarian tissue is seen stretched around the lesion, mostly diagnosed by sampling. Now, there is ultrasound shows complex adnexal lesion which cannot be fully characterized, and then a MRI shows 5 cm fluid structure with a complete crossing it. And so this is denotes parasalpinx. And no ovarian tissue is seen stretched around the lesion, so parasalpinx. And then a 6-week pregnant lady, what is not correct? Lack of detectable cardiac activity in 8 mm CRL MQ is normal, is abnormal. 30 breast lump, perhaps she was metastasis and areas of hemorrhage within it, would take primary tumor, malignant melanoma. Hemorrhagic metastasis seen in malignant melanoma and choriocarcinoma. 31, 4-year-old unilateral adrenal calcification, these likely diagnosed cause is endocardial carcinoma. It occurs in old age patients. 32, which would not help differentiate a true adrenal lesion from a non-structure, mimicking it. It remains contrast medium to ensure a pancreatic mass is displacing the sphenic vein anteriorly, posterior, adrenal mass. Now a mass which is displacing the sphenic vein anteriorly is not adrenal mass. Adrenal mass will displace the sphenic vein posteriorly. Adrenal mass will displace the sphenic vein posteriorly. So this is not have to differentiate into adrenal structure. 30 hours 2 kidney, which is incorrect. The incidence at the top is 1:2000. Incorrect. 34, 1699 mg, which is incorrect. The pure blood flow phase lasts for 2 minutes. It lasts for 40 seconds. Mg, the blood flow phase lasts for 40 seconds, not 2 minutes. 35, solid lesion in breast, which is benign process, large calcification. Microcalcification and malignant, large calcification are benign. 36, anatomy of the breast, which is true. Increased enhancement of normal breast parenchyma during lactation is seen in MRI. 37, suspected pelvic malignancy, MRI shows with TWI shows slight T2 intensity, high signal, high p-value, and decreased signal on ADC, most likely diagnosed high celerity tumor. Because high signal on decreased signal on ADC and high signal on p-value, so it is high celerity tumor, high DWI. 38, 2 cm adrenal lesion, then you have 18 HU before contrast, 68 HU in the portal venous phase, and 57 HU at 10 minutes, most likely diagnosed metastasis. Because greater than 15 HU and less water, just less than 57 HU to metastasis. 29, mammogram shows unilateral diffuse increased density of the right breast with skin thickening, coarse reticular pattern with common Cooper ligament and no macrocalcification, which leads likely granular cell tumor because this common Cooper ligament and then thick coarse reticular pattern, increased density of right breast. So this is all may be seen but not granular cell tumor. 40, anatomy of retroperitoneum, which is true. The right perineal space communicates with the area of the liver. Right perineal space communicates with the area of the liver. 41, that's asymptomatic. Number 5 cm unilateral calcified external solitary renal artery aneurysm. With incorrect lesion should be treated surgically. Because it's less than 1.2 cm, so it should not be treated surgically. It should be left conservative treatment. 42, neonate with abdominal wall defect and bilateral paroxysm, but will not support the normal diagnosis. Top grade low capacity bladder. 43, history of ataxia. CD shows multiple solid lesions within the right kidney and absent left kidney with surgical strip nearby, and multiple well-defined cystic lesions within the pancreas, mostly diagnosed one nipple and down syndrome. All these features are seen in one nipple and down syndrome. 44. Breast lump, which on ultrasound suggests malignant rather than benign cause. It is taller than wider. 45. CT shows large perinephric hematoma, which is least likely cause. Multicyst is plastic kidney. 46. CT shows heterogeneous enhancing mass which does not extend across the midline, displays made vessel, which contains non-associated apoptosis. Wilms tumor is associated with Wiedemann-Beekman syndrome, and Wiedemann-Beekman syndrome is associated with all these conditions, but not apoptosis. 47. IV to bilateral steroid nephrograms, which is least likely myelinosis. 48. A 50-year-old man after acute epidermolysis or foul swelling, red tender scrotum with pelvic capitis, which is true. CT is the best test to investigate the extent of spread. Diagnosis for near gangrene, in that we do CT scan is best to investigate the extent of spread. 49. Renal lesion. CT was 2 cm round, homogeneous, well defined, without calcification and suture in the upper part of the right kidney. 60 on-field unit after administration of contrast increased to 69 HU. Likely diagnosis, simple cyst. It is less than 10 HU increase, so non-enhancing. Sonian legend, first HU 60 and after enhancement 69 HU, so it is most likely simple cyst. 50 ultrasound is partly solid, that's partly cystic midline mass, which would not diagnose ovarian torsion. Enhancement of solid component CT. Ovarian torsion does not enhance on CT. Chapter 4, Lindsay, genitourinary tract. Okay, genitourinary, adrenal, obstetric, and gynecology. Question 1. All of the following conditions are more commonly due to E. coli infection except then the chronic polyneuropathitis. It is due to protease infection. Question 2. 45-year-old woman with menorrhagia. MRI shows junctional zone with measures 13 mm throughout with hyperintense T2W foci within it. What conditions are these findings most consistent with adenomyosis? If greater than 2 and 12 mm thick is seen as adenomyosis. 3. 50-year-old male patient on a long-term analgesia with macroscopic hematuria. Intervention geograms of the filling defect in the distal ureter with proximal dilatation. Ureter immediately distal to the filling defect is also mildly dilated but normal and cerebral vertical down. Diagnosis transgenital because this is called goblet sign. The filling defect in the distal ureter and then proximal dilatation and also distal dilatation. So this is goblet sign. See in transgenital carcinoma. Number 4. Male with palpable breast lump, nodular, fan-shaped, subareolar lesion seen on aerography. Hypochoric on ultrasound is surrounded by normal fatty tissue. Hypovascular flow within the mass is noted on Doppler ultrasound, most likely diagnosed gynecomastia. Male with palpable breast lump is most likely gynecomastia. Number 5. Ultrasound shows 5 cm solid hypochoric mass arising from the right ovary, occurs sharing but no calcification. Most likely cause ovarian masses, fibrosarcoma of the ovary. There is 5 cm solid hypochoric mass arising from the right ovary, occurs sharing and no calcification, so most likely fibrosarcoma of the ovary. Which does not make any sense. No option. Number 6. VCUG shows reflux into the real pelvis bilaterally with mild ureteric and pelvic dilatation but no calysis dilatation at preserved cornices angles. Reflux. Grade 3. Pelvic system dilatation. Grade 3. Question 7. 5.5 cm simple cyst appearing cyst arising from the left ovary. What do? You comment or repeat transabdominal ultrasound 6 times. If greater than 3 cm premenopause and greater than 5 cm postmenopause should be followed up. 8. HSG shows unicoordinate ureter. What other indicator? Imaging, because malignant anomaly is associated with renal anomaly. So when there is unicoordinate ureter, what do we do next? Renal imaging. Question 9. Which form of calcification raises greater sustained for carcinoma C2? Dash. Question 10. Which finding would make the diagnosis of large renal angiomyolipoma more likely than neuroperitoneal liposarcoma? Depends on adrenal blood vessels with a lesion seen in angiomyolipoma. Question 11. Diabetes. CT shows large irregular mass displaying most of the parenchyma of the right kidney with measure 10 into 11 cm in the axial diameter and does not demonstrate enhancement. Mass that have accumulation value between -5 and -15 HU. The renal outline is poorly defined. Cyclone calculus presence to diagnose genital pulmonary. Question 12. Infant with crib autism and dilated bladder and ureter. MCQs of dilated bladder, tortuous and dilated ureter. Dilated posterior urethra and renal cortical thinning. Bulging flank. Diagnosis Eagle-Barrett syndrome. Autism, dilated bladder and ureter, tortoise, dilated ureter, diagnosed Eagle-Barrett syndrome. Concerning what would be suggested of breast malignancy, spike-graded margin. Breast malignancy shows spike-graded margin. Question number 14. CT shows 6 cm enhancing left renal lesion that has fibrotic central scar, diagnosis renal oncocytoma. Although it shows spoke-wheel appearance, the scar does not enhance swollen contrast. 15. Patients with diabetes cities with mildly dilated left renal pelvis may contain small pockets of air extending to the calyxes. Diagnosed pyelonephritis, but what subtype of pyelonephritis is pyelonephritis pyelitis. Gas in the pelvic calyceal system is pyelitis, and if gas in renal parenchyma, then emphysematous pyelonephritis. 16. Pelvic pain. MRI shows 7 cm left adnexal lesion of predominantly intermediate and high signal on T2, but with low signal comment within it. On T1W, there is layer of low and high signal with suppression of the high signal on T1W fat separation. Diagnosis referred for surgery because diagnosis is dermatitis. On fat separation, there is suppression of the high signal on T1, so referred for surgery, dermatitis. 17. Uterine artery embolization, which regarding the relevant arterial not is incorrect. Ureter ovarian anastomosis is identified in less than 5% of cases. The incorrect. Which regarding relevant anatomy of uterine artery embolization incorrect. Ureter ovarian anastomosis is identified in less than 5% of cases. It is common. Questions 18. Bilateral breast augmentation, which finding on T2W MRI are keeping with intracatheter implant rupture. Multiple combination lines of low T2W signal within the implant shows intracatheter implant rupture. 19. 72-year-old man, ultrasound shows uniformly hypoglycemic lesion that is enlarging and almost replacing all of the normal parenchyma of the right testis. Enlargement of the right epididymis is an adjacent spermatic cord. Left testis is 2.5 cm hypoglycemic lesion with normal spermatic cord and epididymitis. Diagnosed lymphoma. With greater than 60 years of patient and bilateral lesions with inferior testes and replacing the normal testes. So this is lymphoma.